Mr. Chairman.
Every time the quality committee meets, I'm gonna use this unless the boss over there says I can't.
Okay.
Okay,
We are live streaming now.
okay. And can I use that if we're out of order or something?
Yes, sir.
Okay, it's been, I don't have my agenda. Can I borrow yours?
Sure.
No citizens signed in, I don't believe.
No citizens.
No.
And that brings us to approval of minutes. Got to circulate ahead of time.
Move approval.
Second.
Any discussion, anybody? You guys okay? All in favor, please say aye.
Aye.
Those opposed, same sign. And that passes. Then there's hospital district policies. And I saw a whole list of them.
Yeah, it was a lot of
Two
them.
policies on the agenda for today. It's EC 3300, Orientation and Education of Custodial and Forensic Officers.
Well, that's not what I got under my, didn't you guys get a list of about,
I think
There-
it
those
was
are- yeah.
procedures. I think it was more.
Right, not for the approval of the
Yeah.
agenda. Those are procedures for, that y'all can see what those procedures are.
Yeah.
But for action by the committee, you have the two
okay.
policies that are
I-
before you.
I read it wrong.
And so your first policy is EC 3300, the Orientation and Education of Custodial and Forensic Officers. It has to do with when police officers are at the district with inmates in their custody, when they're receiving care at JPS.
Everybody get a chance to read it?
Yes.
And then PC 1200, Provision Care.
Can we do them at the same
Treatment.
time?
Yeah. I was-
Okay, why don't you
And
go ahead?
Provision of care, treatment, and services, and then, and that has to do, that's the generalized provision of care, services policy, and so if you wanna go ahead and entertain motions.
Okay,
So moved.
is there a second?
Second.
Any discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. So the committee passed the EC 3300, Orientation and Education of Custodial and Forensic Officers, and PC 1200, Provision of Care, Treatment, and Services.
That's correct.
And then there's committee activity that does not require any action, and Frank is first up. Got a napkin. Just need a napkin, I'll get it.
Here,
Yes, sir.
have an extra
Oh.
one.
Thank you.
Here's yours. That's all right.
From Miss Tammy and,
All right,
yes,
thank-
sir.
Thank you, Dr. Weber. Before I start, I just have a little personal comment that I'd like to make. So it's almost my 1-year anniversary of JPS. So it's just about my JPS birthday.
Oh,
So what I've done, and with the help of Janet, is we have a cake to celebrate this in the back. And I did check with our general counsel, and this in no way absolves me from the debt for our king cake later in carnival season when that starts. But it is evidence of my credibility for that.
1 year,
So
right?
at the break, please enjoy, there's cake back there for everybody.
You need to pull the microphone a little bit closer, I think.
Is that better for everybody?
There you go.
yes.
All right. Should I say that again? No. All right.
Well, Dr. Rossini, I just want you to know that we went ahead and partaked of your cake, and there's none left for anyone else.
Oh, good.
Yeah, it's a former cake.
The former cake. There was one here earlier. Anyway, thank you. I'm glad to get started. So this is my report for today, and this is going to be a data meeting. So we're midway through the year, and I thought let's take a look at some of the outcomes that we thought were important to us at the beginning of the year. And as we look at the outcomes that we will hear around falls, Foley infections, central line infections, surgical site infections. As we hear from the experts that are at the front lines today, I want you to think about how all the work they're doing is really emblematic of a high reliability organization. The picture is, behind me is Kathleen Sutcliffe. She was a professor and researcher on high reliability organizations at University of Michigan. And she was lured away by some money from Michael Bloomberg to Johns Hopkins. But she is what a national expert in this field, and the Joint Commission has partnered with her to take and bring the whole high reliability concept to our hospitals and our care. And the idea around the high reliability is we really want no defects. We want zero infections. We want zero harm for our patients. So when you hear about falls today, and you see the people that are doing the work, Stephen and Sheba and Elizabeth, you will know that these people are preoccupied every day about who's going to fall and mostly who is not going to fall, and how they can match their staff up with the patients that come into the units. They are preoccupied with this, not every day, but every part of every day, with every admit every day. It's amazing to sit down there and be with them. They are preoccupied with failure, and failure for them is a fall. And we're going to hear about that. Reluctance to simplify. We have got a fabulous example on surgical site infections. I asked them to include the process flow chart, because you think surgical site infections, take a bath before you come to the hospital, a few antibiotics, get them out the door. It's just a touch more complicated with that. So reluctance to simplify and really engage around the complexity to give us high reliability and zero infections. They've got a process flow chart that's really going to demonstrate that. Sensitivity to operations. You sense this. I mean, we all have businesses and things that we are obligated to in addition to our work on this board. So when you walk in the hospital and you walk with the nurses, that know the patients, and they understand what the day is going to be like. They are very sensitive around the operations of their unit. They have that sixth sense. I mean, and you have it in your church, you have it in your home. Dorothy, you had it when you were in healthcare. There's a sensitivity, there's an awareness of signals that occur in our institutions, and the better you are around this, the better chance you are for creating a high reliability organization. And then resilience. When stuff happens, how do you react? Because regardless of the policies that we have and the procedures that we try and follow, when people's good intentions, things happen, and how do you react to those? How do you recover from those? And you'll hear about that a little bit today. And then the last one is deferral to expertise. So when we talk about Foley infections today, and there's going to be a bullet point that speaks to nurse-driven Foley removal protocol. It's deferral to expertise. They are at the bedside. They have a really good sense that this Foley needs to come out, so we need to defer to their expertise. Foundational to this work, especially with the preoccupation with failure, is psychological safety. So we've talked about this before, but it's fundamental to high reliability organizations. So if you have a preoccupation with failure, so this is in your mindset to really create a safe environment for your patients. And if you see something and you're not in an environment where you're comfortable talking about it, doesn't matter. If it's your little secret, doesn't work, doesn't help anybody. We've got a really good example of what psychological safety looks like. This is a photograph of Jennifer. So she did something that required a fair amount of courage last month. There was a resident about to do something in an intensive care unit, and she stepped in and did something and stopped it right there. It was something that that we recognized her for, something that benefited a patient, and the resident learned something from it. But she felt comfortable, safe enough, and supported enough to do that. And this is just one of many, but this was amazing, and what she stopped could have been significant. So when we look at high reliability organizations and we try and become one, because that's the course the Joint Commission thinks works for us, that's the course that we think other organizations, like nuclear reactors, I mean, The accident there means something, an accident in healthcare means something. You know, for us to do those things, those characteristics, you're gonna see those today, and you're gonna hear those, and they're gonna hear people talk about it, and they're gonna demonstrate that. So think about those principles. You know, they're in your packet, and as they go through, they'll probably point some of those things out for you. And underline that again is this message around psychological safety. You have to be comfortable enough in your environment to bring these issues forward, and we're making progress. So this is an example of it. And then my last slide. In September, we're gonna begin our discussion, you know, in this committee around our hand hygiene strategy. So we started work on this in March, and we meet every other week. We've got industry at the table, we've got environmental, we've got nursing, we've got infection control, we've got one of those master black belt folks trying to make sure that we march in order, and we've got quality there. We're starting to figure out what this is supposed to look like for our organization, and we're gonna talk about that, because that's fundamental to us delivering good care and being highly reliable. The other part that, you know, that we're gonna talk about is procedural safety. So we've had some discussions about, you know, what it looks like to have a wrong-sided procedure in an organization, and it's sometimes policies and procedures are not adequate. You need to have, this is part of the culture, and part of what we do, you have to be obsessed with the failure around a wrong-sided procedure. And we've got some progress and some traction there, and I'm gonna demonstrate that to you in September. That's my report, and I will take any questions.
Well, Dr. Rossini, I have a concern or a question, I don't know which one is, what category.
I'll take them both, Brian.
The lady Kathleen Sucklet, do I understand you say she is the author of this preoccupation with failure and reluctance to
She is
simply?
a leading researcher in high reliability organizations, and these are the 5 components that her research and has shown to be the components of a high reliability organization. So she's a leading researcher, nationally recognized.
Okay. All right, then, I thought when we received a report last month that said we had 0 falls.
So we had to do what?
We had 0 falls. Didn't we? Am I off
Yeah,
base?
2 months ago.
Caudy and Clabsy were at 0.
0,
Right.
okay,
Yeah.
good, okay. Then under what definitions or are we operating that we were able to be as successful that's different than what's here?
The point is, there is no difference. We were doing a lot of these things, and we were following these, and then, so when I went to CDU, and I talked with Stephen and Sheba, and they showed me what they were doing, I said, do you know these are all parts of a high reliability organization? You know, the work that you're doing, this is what it means. It's amazing what they're doing. So, we are doing it, but we're gonna become a little more formal, a little bit more educated about it, because there's some opportunities to enhance some of the work we're doing, as always. But we're doing a lot of that. And it was fabulous to see, and that's why I wanted to show you today.
Okay. The reason I ask that is because I just want to be careful that we give accolades or credit to the wrong individuals. And that we've seen some remarkable things take place at JPS, and we didn't know Ms. Kathleen Sucklet. We didn't see this, have this. And I just want to be careful that we're trying to touch all of our pillars. We're trying to reach all our metrics. That I want to make sure we don't give her the credit for something that we already been attempting to do, and that's what my concern is.
I understand it. She doesn't get any credit for the work we're doing, but she is the researcher and the author around the characteristics of these high reliability organizations. So I just was bringing her name forward as a point of reference, not recognition, but point well made.
question?
That's it.
Okay. Anybody else got anything for Frank at all?
Before you go, Frank, I would like to, it's probably isn't the right place for it, but I know as we go through, you are presenting information to us on a quarterly basis, and I know we used to get a scorecard, and I would like to see that scorecard, again, on some of the main deals that we are doing for our annual incentive. Remember, it's about 6 months, and so into the year, and so we set up some measurements, and they're all a part of quality, and it's a scorecard that goes with that. And so maybe you could look at bringing that, if not here, maybe,
I can bring that in September or another form, whatever, we're happy to do that.
Okay.
I'm happy to do that.
because in the HR committee, we like to look at it, we need to look at it because
And it tracks
we are
right back to our
measuring,
pillars,
yeah.
just like the
mhm.
rubber mentioned.
Yeah.
Exactly, we've got that.
Yeah.
I'm happy to bring that,
Okay.
that forward. Thank
That's
you.
kind of where I would like to have that, so that as we go along, we can look at that to see how far we're off, because 6 months into the year, I don't want to have those surprises at the end that we get there and we said, oh, we didn't measure this piece. So that's what I'm looking for, okay?
Happy to bring that forward.
All right,
Thank you for
thanks.
asking.
No, I think the really good part of this is the fact that anybody can stand up and say, hey, this is not where we want to be. I mean, don't do that. 10 years ago, it was sort of like, I'm Tarzan, you're Cheetah, just,
Yeah.
but it's changing. And changing for the better. Okay,
Thank you.
you betcha. And there's Laura, she's here somewhere.
Hello, everyone.
Hey.
Oh,
So I'm always very excited to talk about our patient experience situation and data and stories at the hospital. I hear them over and over and over again, and so it's always a privilege to be able to come here and share with you. Today, actually, I'm very excited because this is the end of the second quarter, which has closed, and all of our patient experience data in all 4 of the main areas, so the inpatient, the OR, the ED, and the outpatient clinics ended the quarter at an increase over where they were before, so that's very good news for us. But we still have a lot of work to do. So last week when I was putting this together, Pat Summitt had just passed away. And it really struck me because she is such a huge legend in the sports arena. And it got me thinking about JPS and how much of a legend we are trying to create and build with the people that are there, as well as the reputation in the community and the way that we really are seen across the country and certainly in this area. And she has this quote, which I absolutely loved, and it talks about how fun winning is, but winning is actually not the point. The point is that want and desire and passion that burns within you, that wants to get to a place that creates the legends and that creates the heroes that we see every single day at our hospital. And so it really is about that want and that desire, but it's also about not giving up and never letting up. And that's really the crux of what we do every single day when it comes to the patient experience. We're not perfect, but we certainly are a lot better, to your point a moment ago, than we were before, and we continue to get better every single day. I was struck by when Frank was talking, because it's really very common to even consider patient experience around a high reliability organization. And so I was struck by the preoccupation with failure and the sensitivity to operations and the commitment to resilience, because the work that our team does every day at the hospital is not easy work, and they have to be resilient. So I wanted to show you this because I think this is an example of what we do every day, and I'll talk a little bit about what we're trying to achieve and what we're trying to accomplish at the hospital in order to sustain the results and the improvement measures that you've just seen and become even better. So to orient you to this graph, this is again the 4 areas that you just saw. The first bar where you see the HCAP surveys, that's our inpatient data. The 78.3 is the number of patients that percentage-wise said that we were a 9 or a 10. And that puts us at that percentile ranking of 90th percentile, which is where we ended the quarter. So we ended in the top 10% of the country. Quarter two.
Just one
That's
quick
a
question.
big deal.
9 or 10 on what?
On a 0 to 10 scale,
Right.
the
On
top
what?
box answers are 9 or a 10 is what the patient would need to select in order for that to,
I got it, I got it.
yeah.
My question is really, what am I, as a patient, what am I saying? Rank me on 1 to 10 on what?
On the overall perception of the care that they received in the hospital.
So is it asking them if they think they got a good care?
Yes, so the question is, on a scale of 0 to 10, 0 being the worst experience and 10 being the best
Got it.
experience.
That's all I need.
Yes.
Good,
Mhm.
good.
So the 78.3, thank you for asking. The 78.3 are those patients that said their stay with us was a 9 or a 10, which is hard to get. I mean, if you think about, an 8's pretty good, right? I mean, in our minds, an 8's a B, or along those lines anyway. And what you see is there are a number of patients in the green section of these bars that rate us at the 7 or 8 range, meaning their experience with us was good. It wasn't terrible. We see very, very few patients who do not care for the experience that they had at the hospital. So when you add those together, and you look, and you can do this, across all 4 of these areas, when you add them together, you end up with somewhere around 94% of our patients telling us they had a good experience or a great experience, 97% in surgery telling us they had a good experience or a great experience, 88% in the emergency room, and 92% in the clinic saying that same thing. If we were to move the dial on those that had a good experience to move to find that gap and determine what we can do that's a little bit better to make that good experience a great one, that puts us in the top of the country in every single category. And when I say the top, I mean the top 1%. So what we've been doing is really focusing on building muscle memory within our teams. And that means that we've taken a very targeted approach on identifying priorities for each of our areas, each of our units, each of our clinics. And those are different for every single point of contact with our patient. So based on population, we look at what's most important to them, and then we've been building action plans and developing tactics around that so that we can become better every day. So we continue to do that at the hospital. We will continue to do that. We have already moved the needle in many cases, and when we see that happen, our overall experience in our patient's mind goes up every single time. So that's what we're working on. One of the things, and I'm really excited to show you this, because one of the things that we've really been doing is recognizing our teams for moving that needle in that targeted question. This is an example of perioperative services. They happen to be here today, so you guys should wave your hands, because that's fantastic. Perioperative services is in just about the top 10% of the country as well, and that's hard to do because that number is pretty high when it comes to the percent of patients that rank them high. But this was actually a comment that came from a patient, and it says the info they provided and their skills were top-notch. There are not enough words to express my thankfulness to the entire team. So we got a chance to go up and celebrate with them and recognize them as a nationally ranked unit, and I want to thank them for that. They ranked first place in movement at the hospital, and so I'm very, very, very pleased and excited for that team for the work that they've done. So the recognition is one thing that we do. We also spend a lot of very focused coaching time doing observations, helping teach and coach the leadership team as well as the staff on things that they can do better. And then when they move that needle, we do the recognition piece to celebrate their success. So we're continuing this methodology. We will continue to do it. It takes us a long time to be able to get the muscle memory built to a point where it just becomes part of our fabric. We would not think of doing anything but taking great care of our patients. And I always reflect on something as simple as, if on the clinical side, we were getting ready to insert a needle, and Dorothy, you can speak to this, I'm sure, but if we were getting ready to insert a needle, you would never think as a caregiver to not clean the site before putting that needle in. It's just not how it works. Well, we have to create that same level of urgency on the patient experience side, and that's what we're working to create now. so that it becomes part of who we are, part of our fabric, and regardless of whether you're here during the day, the night, the weekend, whenever, it's the exact same care that you receive. So, I will open it up for any questions that you might have on any of this data or the work that we're doing.
What is some of our opportunities that we need to work at to improve? What have
So-
been identified?
Sure, so they fall in categories, so I'll give you one example that's kind of a fun story. I was actually on T5 the other day, and I was so excited because their opportunity was nursing communication with patients. So before I ever go around on a unit, I always look at their results to see where are they, what's happening, and be able to celebrate or at least know that what work we need to do. So I went up there, and I'm looking at their data, and I ran the graphs and ran the reports, and they are number one in the country right now when it comes to nursing communication with patients. Now, they were not there before. They were at 60-something, around there. So I'm so excited. I get up to the unit, and I said, I wanted to tell you guys, I'm so excited, I can hardly stand it. Here's what's going on, and I go through my whole story about how great they're doing, and they're in the top 1%, and they're saying, yay, yay, they're all excited too. Never one time did they let on that they already knew this, right? I walk over to their board, and there it is, big as day, right? This graph that says 99th percentile when it comes to the way the nurses communicate with patients. That, for me, was a breakthrough, because that's a huge area for us that we work on all the time. Sometimes it's nurse and doctor communication together, and how they communicate in a way that, in fact, that's what it is for perioperative services. That's their area that they're focused on. Sometimes it has to do with medication side effects, and so we put in some tactics on how do we make sure that our patients understand what we're looking for and what they should look for. Those are some of the main ones, but they break down into the main categories of care.
Okay, all right, thank you.
Certainly.
When you rank these, do other people use the exact same system we have?
Yeah.
What percentage of hospitals, are these all sizes of hospitals, or what does this work?
Yeah, so the HCAHPS database is actually every adult acute care hospital across the country. So, and we all use the same survey. It's the same deal.
Okay. And I like the bar graph you had there. Go back to that for a second. If I were to break those out.
This one here?
Yeah.
Yeah.
If I were to break that out by the patient payment method, whether they're paying with cash or insurance, or would this change appreciably if I took that into account?
We can do that. We do have the ability to run reports and drill down to that level. I would have to do that, and I can certainly bring that back and
Yeah,
show
yeah,
what
if
it
it's-
looks like from a commercial
I
side.
think that'd be interesting.
Sure,
To see if there's a real
absolutely.
difference. I don't know if there'd be a real difference. I don't know what I get
Yeah.
from that, but it's an interesting question too.
Yes, so I'll bring that back next time.
Okay.
It
So
is
what-
fascinating.
What
when you
exactly
look
are
at
you
it.
asking for, Warren, that,
Well, I would
What
expect
else?
somebody who has many options to get their care to maybe look at things differently from somebody who doesn't really feel like they have another option for care. And I don't know that there's gonna be a difference. It'd be interesting to see if there is a difference, or if there is any information that flows from that.
So an obvious aspect is if you are getting a charity care, you'll be very grateful, and therefore maybe a little less likely to be frank about things you didn't really like. And
Or
so-
you might be somebody who's totally unappreciative.
Like, no,
Yeah,
I'm not saying
so
it's just a
I don't know.
possibility, and it's psychologically speaking a reasonable one. I have one question.
Certainly.
It's the analysis of the opportunities for improvement, exactly the question Dorothy asked me, reacted me on, but I was wondering about more specific, if we have a way systematically to look at the dissatisfied group and identify what are the reasons, explanations, because that's kind of what goes beyond the general statements about being a resilient organization or whatever. That's where some of the real opportunities directionally.
Yeah.
We have, 3 people, but they had serious problems. Let's look at that. Do we
Yes.
do that? And
Yes.
how much?
We do. We use that a lot, actually. What's interesting about JPS that's different than the other hospitals that I have worked in or worked with over the years, normally speaking, you find there's about somewhere between 6 to 8% of patients that frankly didn't have a great experience at the hospital. That's very normal across the country. We don't actually see that at JPS. We see the more 2 to 3%, so it's about half of what I've experienced in a couple hundred places over the years. The interesting piece is, so that data pool for us is very small on this data. So we have to go to other sources. And what we do is we look at our complaint data, our grievance data, we look at all of those. We're getting better at that, and we'll get better at that over the course of the next several months, that we can actually look by unit to be able to see what were some of the things that came in as complaints or grievances or things that we solved, and how does that compare with the overall experience that we're seeing on the survey
The
data.
small pool of the negatives is not necessarily just a problem, it's also an opportunity. You can actually work much more intently with relatively few complaining or negative customers. You can,
Yeah, I think
follow
it's
up
the
with
gift.
some type of invite to, talk to them or whatever. And I'm not saying everybody, but, some of them, so.
We do.
Okay.
We actually do invite them back frequently to visit with us and share. I believe that whenever someone doesn't have a great experience, there is a nugget that's in there that helps us get better, and that's the gift. And then we take those gifts and we action on those. Yes, absolutely. We do
So-
the same thing with quality
So
data
you
or HR
have,
data, et cetera.
What I was really asking is, it's like, if we're looking at the detailed reports or
Yes.
review, is there an analysis of that section? And
Yes.
maybe you can share it with us at some point.
Okay,
So I can-
certainly. I'll be happy to bring that back.
That would be a great idea, because I don't know who sent me the article, but someone sent me an article, probably was Frank, because he sent me a lot of articles. And one of those was looking at, and I'm not complaining, because I read them and I got some good stuff out of this one. It was talking about when you were looking at satisfaction, is that you concentrate on that opportunity more so than just those numbers, because if you really want to make a shift, you have to look at those negative ones, and that was your focus, so that was part of it, so I agree with you.
Yeah, I agree too. And I will also add that we do a lot of work to gather information from patients that's outside of the surveys or outside of the care line, patient relations line. We round on patients, we talk to patients, we invite them to come to different committee meetings. We invite people who may have had a great experience or not a great experience. We do a lot of work around that to try to make sure that we're hearing the voice of our customer outside of even the formal methodologies.
I will tell you that recently my brother had to be admitted in the hospital, so I was sitting at it at a different aspect. And
Yeah.
as they came around to do their little surveys and talk to us, I was very cautious what I said because he was still there. Now, when I get their survey, I will give them some more in-depth information. But at that point, I was not going to, I took care of the issue, but I was not going to slap the hand I was gonna have to leave to take care of my brother. So I think that when we do some of the face-to-face, you have to look at that. That's a reality. My loved one is still there. I really don't want anything passed around that might, I don't think they do anything, but I'm just not gonna put him in that situation. The same way if I'm at a restaurant, if I'm gonna complain, I'm gonna leave. I just don't think I want you to fix me anything else. So that's kind of the way I look at it. And sometimes when you get some of the questions, you answer them in a generality way because there are some specific, I'm not gonna take anything because I did see some great stuff that was done. They did do a good job. But there was some things that just should not have happened. And, but I'll deal with that in the survey when I get it. But I was not gonna give them that while I was there.
Well, I don't think you're alone in that, and so what we do is train our leaders to really watch for those nonverbals and for the signs that are there that, we might be able to find those pieces that we can
Yeah.
fix, because I don't think you're alone, but anyway, we do use a lot of different methods and modes to gather information. other questions, comment? Okay, I'll
Thank
bring a
you.
couple things back. Thank you so much, I appreciate it.
We've come a long way.
Yeah, yeah, the team is amazing. They're energized and energetic and want to do the right thing, and it's frankly quite a joy to work with them.
Good.
Just one
Certainly.
thing. You know, sometimes, I've been doing this now for about 6 years, and being a patient, looking at the outside, I've now, called myself sort of like a mystery patient. And,
Mystery?
a mystery shopper patient type of person. So what I do is they have no idea in the world who they're dealing with. So I come in, do my little thing, and you know, I'm from New York. When I get angry, I type about 100 words a minute. I'm tearing up that computer going and telling you exactly what happened. One, you're gonna get one too, you know, about the surgical center. And it just seems to me that it's very hard for certain employees to get on board and understand the methodology and the direction that you go into. That's what really irritates me sort of more than ever. Everybody else is sort of getting into it. This is a job, this is a new crew, let's get into it, and while we're here, let's do our job. But that's not what happens in a lot of cases. You still have people that when nobody is around or there's not a manager sitting there bearing down on them, they're gonna do their own little thing, like, you know, and that shows up. And those are the ones that, boy, I'm telling you, I'm just waiting to get my little hands on them, because a lot of times they're the initial person that you meet. And we as patients, when I come in for surgery like I did last week, and I have to go for 2 more next Monday and then in August, and this is my first time in the surgical center, I want you greeting me, good morning, Ms. Calvin, what can I do for you? Please have a seat, we'll register you right now, and just be upbeat, as I have no idea what's going on. And I didn't realize that this was a big, big, big procedure. They even had to meet the people, because I was really gonna get in my car and sneak home. And it's like, no, we wanna meet the person out there. I had to call the man back and say, I am so sorry, but the nurse wants to see you in the flesh. And it couldn't be a cab driver, somebody that I met in Macy's down the street. It had to be somebody that I know that's gonna get me home. And I swear to goodness, I was going to drive my car and get in that car and go home. And it's like, no. So this is a big procedure and whatever. And everybody from there was like, wonderful. I wanted to stay there all day. They were so great. But the initial meeting, I was just sitting there and I was seething. I was so angry. So those are the kind of people that, you know what I mean, they've been there for so long and whatever. We got to get them on board, because the initial ones are the ones that can really, cause you just to have a bad experience for the rest of the time. And it's so wonderful that the rest of the people, the doctors, the anesthesiologists, and everybody just sort of raised me up. And by the time I came out, I was wonderful. But when I had to pass them,
Yeah.
you know what I mean?
They
Not,
stand
So,
out.
not
that's
healthcare.
it.
This is just a welcome, the kind of taking the data. We tend to naturally be focused on quality of care, but that stuff up front can make a huge difference to the anxious patient. And so that's an
That's true.
interesting thing about adding this into thinking about the projection, the feeling that you communicate.
Yeah,
They stand out, for sure.
yeah.
Yeah.
But we'll get it together, don't worry. You know, we will.
We will. We will. Thank you all.
Okay, you have your marching orders.
I do have my marching order. Ms. Calvin keeps me in line, I'm not gonna lie. Thank you all very much.
Thank you,
Laura, thank you. And then we have the surgical site infection update. Yeah. We got some new faces, so
Yes, so
introduce yourselves.
I'm Dr. Dan Davenport, Chairman in the Department of Anesthesiology, and
I'm Gina Boyles, I'm the manager of quality and regulatory for perioperative services.
And so we were asked by Frank to, we both are members of the surgical site infection surgical focus group, and to present a little bit of some of the progress that we've had. We've, been meeting, just a few meetings since January, February. We've had a few meetings and have had a lot of collaboration. So as a background, this committee is not only, is tackling, how we can improve with our surgical site infections for colon surgeries, and we're gonna highlight specifically colon surgeries, but also for abdominal and vaginal hysterectomies and knee and hip arthroplasties. So we're looking at that data and what we learn in these, for example, what we're applying in colon surgeries, there's many elements that we can apply to some of these other surgeries as well. So first off, we're gonna show why do we want to get involved with this? Well, first off,
Can you just advance the slides? I think
Sure.
it'll pop up.
Well, I am also, I'm also like the, I'm not foreign to all this technology, as I'm the IT individual for our department. So I feign, that I don't know what I'm doing. So what I want to mention is that, keeping this in perspective and what a patient were to experience. This is a case where there's a 53-year-old male having a colon resection for cancer, had poor wound healing and needed retention sutures. That just means that it was so tense that the abdomen was unable to be completely closed, and there was wound breakdown and required additional care, additional hospital stay due to this infection and poor wound healing. So this is one case among others of what, and you can imagine what a patient would go through. And I've seen cases that this is just devastating, especially intracutaneous fistulas, where the bowel will drain into the abdomen, and just a very difficult case to manage, very difficult for patients. So example of, and think about that as we go through this, we understand in the committee that these are, we're looking at numbers, but devastating consequences if we don't get this right. And so, we go to the next slide.
I have a question. Was this gentleman, was he ever sent home after the surgery?
I'm not familiar with all the specifics about the case, but, yes, they required home health care, so they were sent home
Okay, so
and they're discharged. They were discharged from the
they were
hospital.
discharged, and this is what he came back looking like
I believe this actually occurred in the hospital.
in the hospital?
The poor wound healing was recognized in the hospital, extended the stay, and they were sent home. This is not a case that I was personally involved in, but yeah. Now, on the next slide, this shows the actual number of colon surgical site infections that we've had, we were limited on slides, but if I were to show you the other slide, you could see that from 2013, our trend is going down as far as our rate of colon surgical site infections. But what I wanted to point out was that each of these cases that you're seeing here, especially, the 5 cases in quarter 2, every surgical site infection has its own root cause analysis and evaluating each point where we could improve and getting a team together to tackle this. Now what I really, the meat of the conversation though is not that. It's the tremendous team that we have on the focus group. So we have individuals from, we have multiple surgeons, orthopedic surgeons, general surgeons. We have pharmacy, we have information technology, because a lot of this can be facilitated by IT. We have nursing, we have clinic nurses, which is the first time I've seen a clinic nurse in a hospital meeting, which was was great, and I'll touch on that, but just an incredible group of individuals that are working together to see how we can improve. So the next slide.
I have a question
Yes.
about that one as well. How many procedures were done in the last quarter?
So the last quarter, I think, from the record, it was like 54.
Okay, so this is out of 54 procedures.
Yeah, I think that was out of 54. Yeah,
Thank you.
so, saw that on there. Yeah, okay. So I put this up here so that you can bring your magnifying glass and try to blow it up. But the point of this slide is to realize that there's been a lot of work from a lot of individuals putting in their 2 cents, and I was just going to highlight, and maybe Gina will also highlight some of the post-op care, but preoperatively, that the first item on here is, patient needs surgery. The first decision point is the patient optimized, and that is a huge undertaking to improve the preoperative preparation for these patients. So we are in the process of working and having nurse practitioners rotate through the surgery clinic to help with diabetes control, with nutrition, and our nutritionists. And it's surprising when I tell this to people, but an obese patient oftentimes is malnourished. And some of these surgical site infections are in our extremely obese patients. And so, nutrition is important. Glucose control. So working on, and a smoking cessation is also a large role. So working on all these factors that really do play a role to prepare a patient for surgery, which I think is excellent. And another aspect is keeping in mind the patient. This looks very complicated, but I'm very proud of our patient education, Leah Maples, that she has this patient education, and some people are visual learners, some read, but it's very clear to the patients, a handout, visually and in writing, what pills to take, what time to take them, and has done an excellent job of that. And all that we're learning from this is also going to be applied in many other ways. We're learning from this, I guess you could say pilot, but how we can help our patients. Another thing I was going to mention is we're incorporating guidelines and recommendations from multiple societies. For example, the Enhanced Recovery After Surgery looks at returning patients to their preoperative state sooner than later. And how do we do that? Well, maintaining good hydration, good glucose control, early ambulation, removing Foley's, that we're going to talk about later, but so that you get patients back eating earlier, and nutrition earlier. So we're incorporating those guidelines along with additional research, into that. So Gina, if you want to share a little bit more about some of the surgical.
So some of the things that came out of the RCAs, or just really down on the injections, was, like you said, the optimization of education. And as the hospital grows and as things move, so many of these patients are not going to be going to pre-decision testing, so their education is going to actually begin in the clinic. So one of the exciting things that we're working with these makers on right now is to create a operative package or a kit for the patient. Currently, when a patient is scheduled, they go to PAP, they're given their hibiclans, or given some instructions in the clinic, given instructions here. We want to centralize all that. They get one set of instructions so that it's clear and understood. That we give them their hibiclans that they use. One of the things that happened through this process, and actually it started about a year and a half ago, some of it did, was to increase the number of showers they take with the hibiclans, which is the 4% CHG, which has a better bacterial kill rate, gets the bacteria off their skin, and the evidence-based practice that we found through our evidence-based practice committees, quality committees in our units, was that they needed to take 3 showers instead of 2. So we changed those instructions, gave those instructions out, and then this year we rolled it out to the inpatients as well. They not only take the 3 showers, the nurses ask them, did you take your three baths with your Hibiclens? We have a set of instructions for our patients who don't have access to running water, and we give them pre-moistened wipes to use. When the patients arrive, their surgical site is washed again by the nurse. And we roll that out to the inpatients, and we've been monitoring it for a month now. And I can say that our inpatient units are at 100% compliance with using the CHG wipes and the showers. Another thing that he touched on was the early recovery before surgery. You take these patients who are having colon surgeries and you make them basically on clear liquids for 2 days. And then you give them a bowel prep, which is just terrible. And then we're gonna bring them in here and we're gonna give them antibiotics to essentially kill the rest of the bacteria in their bowel. So they come in and they're dehydrated, they're nauseated, they're already not feeling well. And then we're gonna give them some of the strongest medication on the face of the earth to put them to sleep and then do a big surgery on them and expect them to feel better when we're done. And so one of the early recovery after surgery initiatives is to give them something to drink a couple hours before surgery that's high in calories, high in sugar, high in protein, that will help their bodies recover from all the bowel prep, and being MPO, it helps them get over their anesthesia quicker. Another one is to increase the amount of oxygen that they're on through their surgery, making sure they're warm. So we've had some initiatives and preventing skin breakdown. So one of the first things that we did about 1.5 years ago was initiate these nasal swabs that are an iodine swab, and they have a 99.9% kill rate for MRSA. And we put those in the nares. We just swab the nares and around the end of the nose of a patient who's going to have surgery. Whether we know whether they have MRSA or not at this point. We can we can treat them when they're in the clinic and send them home, and by the time they come in for surgery, they may have recolonized. So by putting the swabs in their nose, it's just iodine. They can't become addicted to it. The drugs don't become addicted to it. It's just something preventative. And another one is the pre-warming of the patients. Keeping them warm. Getting you warm in pre-op and keeping you warm all the way through your recovery helps you not get a wound infection, helps you recover sooner. And then also we have what we call the Happy Heining Initiative, which is patients who have a low BMI or the extremely obese patients. We put sacral dressings to prevent breakdown during surgery, and those are some of the things that we started. Another one is to streamline their discharge instructions. When patients go home, they get a red folder that has all of their discharge instructions on it. And so if they call with a question, or when we call them back, and we call every outpatient back, and I believe the inpatient side also calls those patients who are admitted and discharged, you can tell them, go get your red folder, let's look at your instructions. Or if they don't remember when their appointment is, it'll be there. We don't send anybody home from recovery without an appointment. One of the things that we initiated in the operating room was something that'll make your surgery infection rate look higher on the national reporting system is if the wound class isn't correct. And so we went through a period of time about 1.5 years ago, where we discovered that those wound classes were automatically being filled in by the electronic medical record, and they were wrong. They were based on the CPT code, not based on the clinical diagnosis of the patient. So we fixed that, and we educated, and we continue to educate, and we're doing really well with that. But we do a post-op brief in the operating room where the surgeon, the anesthesia, the nurse, the scrub nurse, they talk about, okay, this was the surgery that we did, that we were expecting to do. This is what we did, and hey, they had pus in their abdomen. This should have been a wound class 2, but now it's a wound class 4. And make sure that everybody's charting that correctly, because that's going to affect our expected infection rate in the long run when we're looking at this compared to other hospitals nationwide.
So I was just going to highlight, or did you have a question?
I do. There is a couple things about wound care, and it's a big deal, especially for patients who do not have clean homes. or have the, ability to come and see the doctor afterwards. Have you sat down with your IT and to see if there is a possibility of doing videos of wound care and put it on my chart? Because some of them, they don't wanna get up and they don't wanna get out the red binder book, they don't wanna go through it, they don't feel good, they can't, you know, put the energy into reading it and then taking care of themselves. And if they don't have anyone to do that for them, and they could just click on the computer or their phone and say, oh, that's what I have to do. And then they can just replay it every time that they miss a step.
There are some videos for patient education, but I don't know specifically if there's one for wound care. I know that we're looking now to do some clinical education videos for some of the processes that we're doing. One of the big processes that we changed was how we close colons. And we're looking at doing an education video for nurses, scrub techs, and residents and physicians on how that works. So that's something that we can look at. We'll certainly check into it.
Yes, I think that it would be
That's a very good idea.
very beneficial to the patients. I don't think that you, I mean, I'm not saying it would change the numbers, but I think it would help the patient. And everything you're doing is absolutely wonderful, and I appreciate what you guys are doing about stepping everything up and then following up with what you're implementing, especially keeping the patient warm, because their body, if they're cold, they're trying to fight the cold instead of the infection. And keeping them warm, then they don't have to worry about that. Yeah,
And
thank you.
if you notice, we've mentioned the word patient a lot. You know, so this is a patient-focused, thinking, this whole workflow is the patient going through this experience. And so, and three things I was gonna highlight that Frank was mentioning about high reliability organizations. So we're looking at failures and how we can improve rigorously. And then second, to failure to simplify. This looks complicated, but also in the complicated algorithm, you make it simple and clear when you roll it out. And so we're educating individuals in the different areas, so it's very simple, their role. And lastly, the last thing that I wanted to mention was the what success would looks like, and it's really number one. That is, to me, is a huge something that's very successful is the collaboration. We're pulling individuals from many different areas, having them work together and creating something better. And I think that's already been a successful, very successful. Now, obviously, the other results will be that our patients will be better optimized for surgery, having better blood sugar control, but, you know, more nourished. They're getting Ensure for at least like 4 days before surgery, most of these patients. Intraoperative optimization, all these things that we're talking about that we can manage perioperatively to get them as soon to their normal self, you know, and like discharge support like Gina was talking about. And so our observed rate of colon infections is higher than what we would expect from looking at all hospitals, you know, the average. So we want to decrease that so that our observed matches nationally what we would expect for surgical site infections. Not only colon, but all of our surgeries, but colons have been our highest rates. And then we open up for questions.
That ratio that probably reflects the population we're dealing with, right? Would you say that's the expected situation when people don't necessarily have homes that, you know, somebody has to,
You know, that definitely likely would contribute to it. That, you know, patients are, I watched the streaming of last quality meeting that Frank was mentioning. Socioeconomic factors are a large role in quality, you know. So, however, that being said, we don't accept that.
Sure.
You know, we are going to do everything on our side to help them out. But yes, that they already are starting at a disadvantage, and we do our best to change that.
Do you have a baseline for comparing with other similar hospitals? Because that would be an interesting one too.
Yeah, there is a national baseline. There's it's called the SIR, it's the surgical infection rate, and it's compared against your expected rate. And it's compared on a national level.
Like you're mentioning, say, another county hospital like Parkland.
Right, that's
yeah.
what I had in mind.
They
That's what I had in
compare,
mind.
we're compared to like hospitals. I don't know.
Because that would be more fair, and I totally agree with, we don't want just fair, we want to be better than expected. So I'm not-
And for the month of April, we're at 0, and it's taken a lot of people and a lot of work to get to 0 for April. Of course, an infection is reportable for up to 90 days. So that's why the date is only paid. So we can have a surgery and 90 days later come up with an infection, and we're gonna be, accountable for those bad infections.
But one thing that as you've noticed, the patient plays such a large role in this, and we're including them in the education. We realize patient education is huge, keeping them involved and included, because we can do as much as we want when they're in our hospital, but we need to help them get into the, have the right habits, the right, do our best to take care of them, and it starts before surgery. That's one of the biggest pieces.
I have one question on when we are patient being optimized, and you have a nurse practitioner, advanced practitioner there. Are the bulk of your patients coming without a primary care doctor?
That's a good question. For our surgeons, because I don't know offhand the answer to that, but I know that many do have a primary care physician, and when we had our clinic nurse at our meetings, she said, "This is great. I now know what you are looking for when you're going to schedule this patient for surgery. I will work on, this with the patient." So we'll be rolling this out so that the primary care physicians, before they even send the patient for consult,
Right.
will be working on this.
Okay.
Right.
Because I'd like to see, one thing you add to it, is the number of patients that are being followed by primary care doctors and the ones that are just come through the emergency room without any. I mean, if we have a large number of primary care providers, patients are being assigned to them. I would hope to see that they have been involved in this care,
Mhm.
and that would just be one more piece of this review,
Yeah.
okay?
Yeah.
Thank you.
Anybody else?
I have a question. For the people that do not have homes that are having surgeries, is there a place that you can tell them that they can come back and you can clean their wounds for them? Is that part of the discharge? Because if you're releasing them and they're leaving and they're not getting good care out there because where they're living, and if we had a place to be offered to them that they could just get their wound cared for.
I think you're telling me about.
There is a wound care clinic, and if they could be referred to the wound care clinic by their surgeon, so then they could come back into the wound care clinic to be checked if they weren't able to come back to a regular appointment.
Is that part of the discharge that they know that?
I don't know. I don't know the answer to that.
But with all the analysis you've done, I bet you can identify the 10% that should probably be recommended or suggested to visit you know what I mean? You will recognize it as the obesity, the other factors, and those could be kind of like encouraged to do that, right?
Well, one of the problems that we had in the past were patients not coming back for appointments.
Yeah.
But that's pretty much been resolved, where they have an appointment before if they're a day surgery, they have an appointment before they leave the PACU. And if they're admitted to the floor, they should have an appointment before they leave. So they should know when they're coming back to get that wound checked and when to take the dressing off. That's part of our next steps of our project, is to streamline those those instructions, and we'll be looking at those processes about whether they're getting the wound care, especially the part of our population that's underserved or homeless.
Right.
They need more help, and hopefully we'll be able to identify where they need more help and get them in the right direction. That's where we want to be.
Is there a possibility of getting in-home service for them if they can't get out to take care of the wound?
Do we have home health?
Well, I believe so, but some of our patients, are living in shelters and things like that. So the ones that are at home and they have, some sort of type of home care benefit, I'm sure we have a very good,
Our challenge is in that regard, our challenge is not those that have a home that we can identify. We have services that we provide. What Gina spoke to is our biggest issue, and that is people who are homeless or transient in some way. And so what you try to figure out is what you can equip them with for a 24 or 48 hours after they're discharged from the hospital to have some type of care. If you can get past that time period, your odds get a little bit better. But those are our challenges with those who are transient or don't have homes.
Right.
Thank
We
you.
struggle with that.
Thank you for that.
Okay, good work. It's a very complicated issue, very complicated. Thank you for coming in.
Thank you.
Mr. Chair, if I could, I wanted to give you all an update that Gina and Dr. Davenport and Stephen and Dr. Gollop and the others that you're seeing and the folks that are our citizens on this, I think it's a good opportunity for all of us to take a bit of a break and understand that it's a new issue when you see people like this. This committee has done great work with Dr. Weber and others to bring these people who are doing the frontline work so the citizens that are listening to this understand what JPS is doing. You all as board members understand what JPS is doing, because these two wonderful people and the people that y'all are going to see coming up next, they make JPS what it is. And you all provide the direction for that, but I couldn't be more proud of them and how they do things. And this committee and all committees at JPS have never really seen this level, and I'm really pleased that everybody is so willing to come and talk about their issues and what we're doing. So I can't applaud y'all enough, and the rest of y'all that are coming up. This is the fabric of JPS.
Thank you.
Thank you. We'd like you to come back too.
Leave the chair, Regina. I think you put another one up there.
Run right down.
I'm also glad that we are saving the county a lot of money by not having air conditioning on today. I think the citizens should know that
How are we saving money?
there's no air conditioning, obviously, or at least a minimum amount. So we're doing well on behalf of taxpayers.
So noted.
I didn't mean to just look at you. I'm just saying the taxpayers should be happy we're not spending any air conditioning money today.
Go ahead and do it.
We're close to the hospital. I was about to say, we're not at the hospital, so you gotta be careful.
Okay, welcome. Could you introduce yourselves and give us a little history?
I'm Elizabeth Rogers, and I'm in charge of fall prevention. Please use the mic.
I'm Stephen Heinrich. I'm the nurse manager of our clinical decision unit. I've been with JPS for a little bit over 5 years, and I think it just gets better every year.
These are,
My name is Sheba Thomas.
Please use the mics or they will not get it on the live screen. Thank you.
My name is Sheba Thomas, and I'm one of the team leaders in CDU.
I still
And
can't hear.
this October, it'll be 10 years with
Can't hear.
JPS.
That was amazing, because you put the mic right there and it did absolutely no difference. So I don't know. We'll communicate with the board.
Can you hear me okay?
Yeah, it's something
I guess you'll have to be like us.
you. It's just Stephen, maybe. You're just the bold voice.
Spares. We got a spare.
Here, we got another.
Here comes help.
We aim to please.
So now we are moving to fall prevention at JPS, and predominantly what we're going to talk about this afternoon is our inpatient falls. Whenever you think about falls in the hospital, it is, whenever I tell people what my job description is, they think it's funny because people can't, outside the hospital, can't imagine why in the world would you think about fall prevention in the hospital. But as just as a little statistic for you, in the United States, over 700,000 people in hospitals fall every year. And it's a big problem in the hospitals. You don't want to have anybody come in to the hospital and fall and have something, become worse, stay longer in the hospital, or maybe have to have surgery from a head injury or a bone fracture. So our goal is to have zero harm from fall, zero harm in the hospital. Just briefly, a definition of a fall is a sudden, unintentional descent to the floor or an unintended surface. So people fall in the trash can, they fall on the toilet, they fall all different places. And so we had to make our definition pretty specific. Nursing especially want to know what the definition of a fall is, because whenever the patient goes to the floor, they want to know, they want to know the specifics of what makes it actually a fall. So whenever we're talking about falls, we're talking about a complex situation. You are, for a nurse, for a tech, on the floor, there are so many different considerations that they have to look at in each individual patient, every single patient. And this slide just shows just a few of them. As far as fall risk screening, there's at least 14 different things that a nurse or a tech have to look at in each individual patient whenever they do the initial screening of whether or not they're a fall risk. Things like their mental status, their gait, do they have a history of a fall, are they depressed at this time, what's their age, so 14 different things. It takes the communication between all the disciplines, the techs, the physical therapist, occupational therapist, any person that touches that patient has to have the communication that this patient is a fall risk and the reasons why. And then also there are more than 30 different things that every different patient has to have considered to keep them from falling. Environmental issues that they have to look at, the height of the bed. I'm sorry, I'm just blanking out. Medications, good, thank you. All of the different things that each patient has to have interventions to prevent falls. So last year, we had 8 injuries, and I know in the past, injuries were reported to the board. So last year we had 8 injuries. This year, so far, we have only had 3 injuries, and we're very pleased with that. Our goal for this year is to have less injuries than last year. As far as total falls, we have had 268 falls in the inpatient areas this year. That's about 73% of what we had last year. We're a little bit ahead of what we had last year, and I will tell you that we're 5% over what we had last year. One of the reasons, or we've drilled down to see what the reason is, and the increase has become prominently in our psych areas. The psych areas have expanded, they've changed locations, and in one psych unit, their increase was 1,490%. Another psych area, their increase was 390%. I know Frank said earlier, Dr. Rozinia said earlier about high reliability organization and what difference does that make. It does make a huge difference, because in a high reliability organization, and I'll take ownership of this, I should have foreseen the changes in psych and been proactive in their changes and supported them more than I did. So anyway, this is our increase. The good part about that is over the past 2 years, or we've been working on falls for 3 years, the previous 2 years, we decreased our inpatient falls by 25%. So not that our 5% is good. It's definitely an opportunity for improvement. But it's just something that in a high reliability organization, I think there would have been measures set up to be more proactive than what happened over the past few months. Change doesn't happen unless it happens at the bedside, and especially falls. I mean, as far as a fall coordinator, I can talk, I can teach, I can provide support, but until a unit themselves decides to change, there really isn't change. The change is just temporary. Literature says that it takes about 5 years for a culture to change, and I think in the past 3 years that we've worked on falls that we've had a huge culture change. I want the CDU to have time to talk about what they've done, because they are an example of what culture change at the unit level is all about. They did not have a fall from December 17th until May. I'm sorry, longer than that. I'll let them tell you. But the funny thing about it is, I used to give fall reports. I still give fall reports, but they were always the highest for their areas. And so now they're the lowest. So I'll let them talk about themselves.
All right, thank you, Elizabeth. I think one of the main reasons we've done so well is because Elizabeth's office is right down the hallway from mine, so we get to share data and information and what's going on, and she's been a big benefit in raising awareness and doing lots of work to prevent falls. Our 3-year journey, approximately 2 years ago, I guess 2 fiscal years ago, we had 24 patient falls, which wasn't necessarily a bad number. None of them were falls with injury, but we had 24. The following year, we lowered it to 16. And when we were looking at our goals for the current fiscal year that we're in, we thought, well, how much lower should we go? And we thought, well, we need a number that we don't need our toes to count. So we thought 9 would be a good number to target. But at the time, I remember kind of taking a deep breath, thinking, can we really do this? So we dove into it head first to work on. And so far for this fiscal year, we've had 5 falls. And with less than 3 months remaining in the fiscal year, we're well ahead of being able to reach that goal. One of the things when we started our journey a few years ago was that I always share the fall data shared with staff at every staff meeting, so everybody knew how many falls we had. We could kind of track our progress as a group together and how we were doing. Then the next step to elevate that was when a patient did fall, Elizabeth had huddle reports that we would complete. So we would basically share all that information with the entire staff so everybody could kind of look at it and see what happened. Everybody could see the staff that was involved with the patient care at the time of the fall and be able to learn some things from that as well as raising awareness. And in December of this current fiscal year, we actually had 3 falls. And so all of our other, the remaining 2 have occurred outside of December. And we began to look at some commonalities between those particular falls that seemed to group together in December. And we found that a lot of them were happening kind of right before shift change, that sort of thing. So we made our 6 o'clock and 6 o'clock rounds a little bit more robust to check specifically for any issues that might, that we might be able to help our patients out with during that time before the shift change. Maybe that's when the bladders were full or whatnot before that time. So we looked at that to reduce it as well. And then Sheba has actually done some fun stuff with us as well. And actually, I'll let her tell you a little bit more about it. But she's begun sharing who the highest fall risk is in the department at our beginning of shift huddles. So we can identify the nurse that is caring for the patient with the highest fall risk and raise awareness even further. So I'll let Sheba speak about those processes.
Sheba, before you start, Steve, what is the clinical decision unit?
We are one of 3 departments that are part of emergency services. So we're not necessarily an inpatient unit, and so some of our baseline metrics for looking at falls are not necessarily widely standardized. We just knew we were trying to go lower and lower with the number of falls that we have. Our patient stay is measured in hours, not days, and typically patients will stay 20 to 24 hours, almost like an ER short stay type of area. A lot of chest pain, a lot of stress tests, a lot of COPD and asthma exacerbations that the decision piece is, do they need to be admitted or not, or can we kind of right the ship and get them going in the right direction and maybe discharge them without an inpatient hospitalization?
Okay.
Does
Great.
that answer your question okay?
Yes,
All
it
right.
does.
Thank you.
So my role as team leader is to like look at the fall data when I come in first thing in the morning. So I'm looking at the scores, the fall risk scores, and I identify whoever has the highest fall risk, and we do a huddle at 6:45 in the morning, and I bring up the fall score, and I will identify the nurse who has that patient and let all the team members know, okay, so-and-so has the highest fall risk today. So let's be all aware, and it's a teamwork. So when everybody is aware of that, they all try to pitch in and put their teamwork together. So that's what we started doing, and it has brought a tremendous difference in how we look at falls.
Okay.
Any questions?
What happened in psych? What was the story there?
They have changed, I'm sorry, they have changed locations, and they opened up a new building, and 2 of the units moved over to that building.
And the building was not designed the way it should have.
I think it was just the upheaval, and I don't think it was the design.
moving?
I think it was just the change in the normalities of their units.
Got it. So the patients found themselves in a new environment and kind of stumbled and.
Well, psych falls are difficult because you have a lot of attention-seeking behavior.
Sure.
You have some aggression. So they're a little bit different than the normal inpatient falls.
They were not happy about the move and started falling more?
Maybe so. They didn't like the room.
One last question.
Yes.
No, I am under the impression that, it's kind of, I'm getting that as a patient, I can tell about increased risk for the falling.
Mhm.
And in those interactions where I can ask for somebody to help me to the bathroom or not, there may be days when I should be asking for that help. And I wonder if you had that type of input, like talking to the patient, finding out those patients can actually say, today I'm okay, but next day they need a little more.
Yes, but one of the top reasons why people fall is because they don't realize their limits. They come into the hospital, they're sick, and they want to do everything that they do at home. And so in the inpatient areas, we encourage all patients to call for help. And whether or not those patients are compliant is why patients usually fall.
Right, and my point is actually that those people who say they think they're okay, they lie in some
Yes,
cases.
absolutely.
And what I mean by this is they don't want to bother.
They are.
Yeah,
They don't want to bother
they don't
the
wanna
staff.
interrupt, they don't want to,
They don't want
feel
to-
they would be obnoxious if they called
Yes.
twice the
Yeah.
same hour.
Right.
We
Right.
have to heavily reinforce that with our patients, and many of those in our area, because they only stay such a short amount of time. They're used to taking care of their own business at home. They don't call for help ordinarily. So you have to sell that to the patient that they do need to call for help.
Yeah, and then we are available and happy to, and it's
Yes.
much better for
Yes.
all of us.
Or some of them, we
If you
demand
call.
or threaten them if they don't call. So,
Hourly rounding is very, very important in fall
Right.
prevention, very important.
Sounds like you folks are doing good work.
Thank you. Thanks.
thank you.
Let me share a short fall story with you. 2 weeks ago, as I was leaving this building, there's about 8 steps down the side over there. Well, I got about halfway down, and then all of a sudden, I did sort of a triple dullivugger, twisting jibba and I landed face down on the concrete.
Yep.
My soda, my hat, my briefcase, and there were two people out there. One was a citizen I did not recognize who came up to give me some help, and my friend, Reverend Ralph Waldo Emerson, was there, who was also giving me some help. And after I got up, I thought, you know, it's sort of like gymnastics. I'm going to see what my score is. And the only person that I could look at was Ralph, and he went like this. I thought maybe I'd get a 2 or 3. He wouldn't even give me a style point.
He didn't want
Okay.
you to repeat it.
That's my story. Thank you very much for.
Thank you.
You got a worried store from me.
Yeah.
Yeah.
You betrayed.
We might need y'all's intervention with Dr. Weber on occasion, but
Yeah,
we're
but see,
gonna.
if a surgeon hits his head, there's no damage. I mean, you worry about your hands and your eyes. You hit your head is nothing, man.
Elena, Dr. Gallup.
It scared me too.
You can't catch it.
You got me? Okay.
Hello, everyone. I'm Dr. Vitaly Golubin. I'm actually
You're Dr. Who?
Dr. Vitaly Golub.
I don't understand the second time either.
This is a very tough committee.
Not a problem. Lena Bauer is actually the infection control director for JPS, but she's dealing with some health issues, so I'm going to present for both of us. And I'll give a little bit of a background, I guess. I've been at JPS for about 3 years, just over 3 years, and the majority of what I do is just routine infectious diseases consults, anything from diabetic feet to weird fungal infections that you don't really see anywhere else. So when I came here, the first 2 months, I was just had a bunch of wows, things that I've read about in the books, and I had to study for my boards, and all of a sudden I see 2, 3 patients with this, so it was a big eye-opening experience. I really had no interest in infection control when I was training, because it's not really what you sign up to do when you're studying to be a doctor, but then I had some eye-opening experiences. So one was where I used to work, we had a large outbreak of Norwalk virus, and I don't know if people have heard of that, but it made tremendous changes just on that floor where they had the outbreak. They had people be out sick for several days, and actually my ex-partner, when I was in private practice, he calls me on Saturday morning, he says, I think I have the Norwalk virus, can you cover for me? So kind of that, and I've seen some healthy patients develop C. difficile infections and become very, very ill. And I've seen that infection spread very readily if infection control is not really exercised appropriately in hospitals. So that kind of raised my interest in infection control. And I did some infection control prior to JPS, and I've been the hospital epidemiologist since June of 2013. So am I going the wrong way?
Yeah.
Okay, fine. So we have made tremendous changes since 2013. We've definitely had opportunities, and as I'm hearing from others, there were definitely some opportunities a few years ago, and we've been able to decrease our infection rates down to 0. So just a little bit of a background. So I'm sure you guys have heard about CAUTIs and CLAPSIs, and they're really infections that are kind of an annoyance, but definitely more so. You know, they carry morbidity, sometimes mortality on patients. They cost a lot of money, and they bring patient satisfaction scores down by quite a bit. So there's a national drive to bring these down to as much as possible just throughout the country, and this is really a big deal nationwide. So we have done a lot of changes, and I'll get into that just throughout the slides, but first just to I guess brag about our successes. So one of the units, the P5 unit, we've had no CAUTI for 13 months, despite having the fourth most Foley line days in that time frame. And the ICU, we have had 19 months without a CLAPSI, despite having 2.5 more central line days than the next highest unit in that time frame. E3, 8 months without a CLAPSI. And for the last few months, we've had 0 CAUTIs and CLAPSIs hospital-wide for the months of April and May. So does everyone understand what CAUTIs and CLAPSIs kind of mean? Or should I briefly explain?
Give us 20 seconds on each one.
Yeah. So
Go ahead and explain.
Other people may need a refresher.
Hypothetically speaking.
Why don't you, I want to make sure everybody's up to speed with the rest of us.
Why don't you do both?
Yeah. So very simple. You come to a hospital and you get a Foley, and you get it taken out when you no longer need it, and life goes on. In a CAUTI situation, you get a Foley and you develop an infection related to this Foley, and that counts as a CAUTI, a catheter-associated UTI. And there are definitions and criteria that we in infection control deal with, because they get the data, and then we have to dissect it and see what qualifies, what does not, and then we have to submit it to NHSN, and that counts as an institution CAUTI. Sometimes patients come in with Foleys, and if we don't maintain them properly, it looks like the patient had gotten a Foley-related infection in the hospital. So that's another area that we're definitely looking at. And in terms of CLAPSIs, these are the central line associated bloodstream infections. Very similar. Someone comes to the hospital, they're in ICU, very sick. They need 15 different medications. They get a central line placed, and if everything goes well, it gets taken out when it's no longer needed. And if it does not, they get an infection related to that, and that counts against the institution. So I thought this was interesting. I just kind of looked up the risk factors just to refresh my memory in terms of what constitutes a risk factor for a CAUTI. Having the catheter in for a long time, being of female gender, older age, impaired immunity, disconnection of the drainage system, meaning if the Foley catheter and the bag are manipulated, lower professional training of inserter, placement of catheter outside of OR, incontinence, diabetes, colonization of the surrounding area, renal dysfunction, and being on orthopedic or neurology services. So as you can see, there's definitely some areas that are modifiable and some are not, and that's, as an institution, that's what's being done, not just at JPS, but everywhere else. So what we have done so far, I think the biggest contributor are really the staff that are on the floors with the patients, and those do include the RNs, the quality nurses, and the clinical mentors. And they really are the ones who push best practices. And just to ride along the high reliability institution, this is really what brings our rates down. Just looking for opportunities and just making sure that things don't happen before they do. Our contamination rates have dropped as well with just educating our staff. And this means, what contamination rates means is really the collection of the urines. If someone is not trained sufficiently, they can go ahead and collect the urine from the Foley bag, send it to the lab, and under the right circumstances, that's gonna count as a catheter-associated urine infections. So we have really drilled down and made sure that the staff are collecting their urines appropriately. We also have reports in EPIC, which is our electronic medical record, on central lines and Foley's, and those get reviewed by our quality nurses. We are working to have the nurses themselves being able to remove the Foley catheters, and this is supported both by myself and Dr. Duane, and that's really gonna, I think, decrease those extra days that the patients do not need those Foley catheters, where first-year resident may forget or say patient is leaving in a day, and those really are critical times that the patient may still develop that infection. It's gonna hurt a lot of people. We have CBL created, and this is going to be provided to the clinical staff as well as physicians, just to stress education more.
What is
What's CBL?
CBL is it's a learning exercise that case-based learning.
learning?
Yeah.
Okay.
Good.
Get your system.
Okay, I'm still.
And,
Gotcha.
And we do this yearly on multiple things. We have a whole CBL on infection control, where we talk about things like C. difficile and line infections. So our ICU is actually adding a second quality nurse just to help bring our rates down more. In terms of physician education on initiatives and definitions, we're really still working with our physicians and advanced practitioners on who really needs the Foley catheters and who does not, and there's always opportunities, and not just at JPS but at other institutions. So we're doing a lot of education from that standpoint. We're really encouraging our medical physicians and advanced practitioners to document symptoms. And this really drives along the NHSN definitions of what is a catheter-associated UTI, whereas something that's not termed to be an infection. So I'll just give you an example. So someone has a fever and they just happen to have a Foley catheter, and if this person has other sites of infection that we can document, that we can say, this is really not a urinary tract infection, we can present this to NHSN and say, this is really not a UTI, okay? And if the physician just documents things appropriately in the chart, we can really defend this much better. Same goes for orders, timely discontinuation of Foley catheters, and like I've mentioned, we're going to have a standing delegated order where a nurse will be able to remove the catheter if it's no longer needed. Sometimes, since I'm the director of infection control, the floor nurse will call me and say, hey, we're having a hard time removing this Foley catheter. Would you be able to speak to the physician in charge of the patient and just kind of explain what's going on? And we'll do that occasionally. And the idea is just to make them understand that we're not out to get them. We're really trying to provide better health care and provide patient safety. In terms of infection control, we're going to have a representative attend trauma meetings and serve as subject matter experts on definitions of reportable CAUTIs and CLABSIs. So really what this means is our infection control staff will get the data and the statistics on our bloodstream infections as well as urine infections, and it's really up to the infection control department to present this correctly to NHSN, so they can agree or disagree whether something does or does not constitute a true CLABSI or a CAUTI. And both myself and Dr. Duane, we review these. Dr. Therese Duane, she's one of the trauma surgeons, but she's also a quality officer. So we review these infections, and we determine whether something is really an infection or we have something else that we can attribute this finding to. I'll give you a perfect example. On our cancer unit, patients will often receive chemotherapy, which will make them neutropenic, meaning drive their white cell counts to 0. And they'll get prophylactic antibiotics, but occasionally they'll have a bloodstream infection. If they have a central line in place, this triggers an event for infection control, and they have to see and determine whether it's a real infection or not. And actually there is a criteria that disqualifies this as a CLABSI. There's certain criteria, but just by reviewing this, we can say that we do not have to count this as a CLABSI because this person has a disrupted mucosal barrier in their gut, and this is where the bacteria is coming from. It's actually not their central line, and this is per CDC definition of this. So that's kind of where we come in helping our infection control officers. In terms of quality, we have definitely made tremendous improvement. We have an insertion bundle for Foley catheters as well as maintenance bundles. In the insertion, whoever is inserting the Foley catheter will have a buddy who will monitor that person and make sure that the insertion is done correctly. Hand hygiene is stressed. Chlorhexidine wipes are also stressed. We've had some issues with securement devices, meaning the Foley needs to be secured to the person's leg. Otherwise, if it goes back and forth, that's a big risk factor for catheter-associated infection. And we're actually, I just found out we're getting new Foley kits which will have the securement devices in there, which will help us as well. We also have a maintenance bundle, and there's documentation in Epic for the nurse taking care of the patient, and they look for things that predispose to catheter-associated infections. So sometimes someone will forget and leave the bag on the table on the patient's bed, and that can have urine flow back into the bladder. That's a risk factor. They have to make sure that the Foley itself does not curl up. That's another risk factor. I again wanted to stress that there's been a tremendous collaboration just between everyone, the nursing staff, the quality nurses, infection control, as well as IT, just to move forward and standardize things and make sure that everything is being accounted for and that we're all on the same page. And again, we have not officially gone, as a high reliability organization, but we definitely have taken the steps to go that route, and just making this official, I think, and just making everything official helps it go in the right direction and help the institution decrease their infections. I'll just mention that in terms of our central lines, we have been monitoring appropriate use as well. When I just started here, I saw femoral lines in the ICU all the time. I hardly see any. In fact, I haven't seen any in several months now. Femoral lines are a big risk factor for line infection, so we're removing them much more promptly. We're stressing PICC lines, as PICC lines seem to carry a lesser risk of central line infections. I went the wrong way, sorry.
Yes.
As I've mentioned before, the near misses, we review many of our bloodstream infections and UTI to make sure that they're reportable versus being non-reportable. In fact, we just had an audit by DHS, right? And they had very positive things to say about our department. I'll just quote. They said that your infection prevention department is doing a great job. From conversations with staff and observations, the teamwork and the staff and department involvement in reducing infections was evident. The infection prevention team has good knowledge of NHSN definitions and their processes meet requirements for complete and accurate data. The staff are very comfortable with the current process for surveillance. So this was very encouraging for us. And I've mentioned about Epic. There are pop-ups and just documentation of our catheters and their necessity, and this basically drives along the same idea of removing unnecessary things and just getting everyone involved and making sure that they're following the appropriate guidelines and appropriate techniques. And I think that's it. I'll take questions.
Good work.
On your report about that one, urology indication, RN ordering, are they ordering a report? What are RN ordering?
So the urology indication, it's somewhat of an idea of its own. A lot of the patients on urology service will require Foley catheters for longer than would be required otherwise, because they had surgery, because they have different indications. So, and we've seen some people order Foleys under that urology indication. So we're working out a process where this is monitored and make sure that all the Foleys are in because they really need to be, not because someone is ordering them under this urology indication.
But that has no indication that nursing is going to be ordering Foleys.
No.
And that leads me into the one about the pending approval. Nurses make rounds with doctors that call them all the time and talk to them about issues. I'm just a little concerned that we are now saying, okay, nursing, you can now decide to, with standing orders, to DC a Foley. We make rounds with doctors every day. The doctor's there, they talk. You mentioned that the nurse have to call you when the doctor won't do it. I'm concerned that if we do that, you're putting nursing in a position where they are not practitioners to order. You know, you have advanced practitioners. So that's just a concern I have, because that's a communication and collaboration between physicians and doctors when they're making rounds, and not just to say, we're gonna do a standard order and let nursing decide when a Foley should come out. That's my concern.
That's a very valid concern, and we have clear indications and criteria of who is able to have their Foley removed. And there's going to be continued communication. If the nurse is not comfortable, they'll definitely contact.
I am concerned, number one, is legal, and that's because nursing is not supposed to order procedures and medication. That is not something that the state board allows us to do. I'll get with Wanda on it, but that's a question I have. But I'm also, there are physicians that are responsible for the patient. They are making rounds, nursing is there. The communication and collaboration should be, doctor, I don't think this patient needed. There's criteria for them to talk to him, then the doctor can DC the order. That's just my concern. I just feel that is something that I'll talk to Wanda about and make sure that nursing on the side, with some standing orders, we can do, but nursing still can't do it. Like a standing order that they said patient can have a range of medicine. No, they can't. The doctor has to order the amount. So I haven't done nursing in a long time, but that's just a red flag for me.
Okay.
So yeah, and I'll just say one more thing. We have standard delegated orders for things like vaccination, so influenza and.
Yes, you do, and it's specific, and the doctor has ordered it. So.
And we definitely have criteria. We can review this, but we definitely have criteria where if they do not meet those criteria, the Foley stays in. So.
And all I'm saying is that doctor has that same criteria that he is looking at. He is treating that patient. He's responsible for that patient. So why say now nursing you can order, you can DC it? That is a physician whose job is to order a Foley or not order a Foley. So I just want you to hear my concern on that.
Thank you.
Okay.
Other questions?
No, we'll get Wanda to
Yeah.
Okay,
Yeah,
Oh,
we'll
yeah.
have that discussion.
good work.
Okay, thanks.
Any other questions? All righty, thank you. We're running a little bit late. I've been told that we do have something for a closed session.
Yes, sir.
So, using my Rosinia, we'll how do you say this? Okay, reconvene in open session.
meeting.
I'd ask for a motion to approve.
So moved.
So moved.
Second.
Motion to approve what? Motion to approve the,
Appointments and
Appointments and
reappointments to the
reappointments.
medical staff.
Privileges.
Privileges.
I second it.
Any discussion? All in favor, please say aye.
Aye.
Those opposed, say no. Any other business? We're adjourned.
Every time I hear that, I think about school bells, and they used to alarm, and we never.
You know what I was gonna do? I thought about this. Have you